So this is another interesting phenomenon, toxic shock syndrome. Fortunately, it's not very common because more and more people are becoming aware of it, and so we are not using highly absorbent tampons anymore. But still, this can happen, and in the past, it was very common. So it will probably stay with you for a while. So make sure that you become familiar with it. So there are symptoms that people present with. So these patients usually, like the name suggests, it's a shock. So they don't come in with regular simple symptoms. They usually have fever. They have a lot of systemic symptoms. For example, they become hypotensive now because of the shock and sepsis. They start to show skin changes, for example, macular erythema and desquamation, or the peeling of the skin. And then finally, multiple organs get involved. So this becomes like a cascade of complications. The culprit bacteria is Staph aureus or MRSA. So you just have to keep that in mind, which will cause toxic shock syndrome. Pathogenesis is through multiple toxins. So this is not your regular pathway. There are multiple endotoxins and exotoxins involved. So those are the super antigen is the most important because it leads to all these cascade of reactions. And then the treatment of choice, if you suspect somebody with toxic shock syndrome, which would be the case when you see somebody, for example, who has developed fever and is hypertensive, and they've developed some skin findings, and now you just realize that they have a tampon, and for whatever reason the patient doesn't remove the tampon, or maybe is in a situation where they are unconscious, for example, and they had not removed the tampon before they became unconscious, you will suspect this. And so basically, first of all, you will remove the tampon. That would be the first thing to do. And then you will start the antibiotics. Vancomycin is the drug of choice for this. And then you can also use some of the other antibiotics, for example, clindamycin and linezolid or immunoglobulins, to combat the phenomena of multi-organ involvement. Some of the other complications are multi-organ failure, finally, and then DIC. These people can go into disseminated intravascular coagulation, so that is important to remember. And this, when they get to this stage, this is basically a point of no return unless you just do a very, very strong or and comprehensive treatment. This slide just shows, a quick snapshot of what happens. They develop high-grade fever, desquamating rash, and then they have desquamation of the palms and feet, vomiting, diarrhea, hypertension, shock, and finally confusion. This is a macular erythema of toxic shock syndrome. So you can see a lacy pattern. So it's not necessarily a very pathognomic of the shock, because it's a very, you can see it's a very simple erythema. But this becomes very significant, because when you start to see desquamation of the skin, then things have gone too far. Next is infection of prostate. So this will of course occur in men only, and people can come in with very similar symptoms as female patients, that they have pelvic pain, then they have fever, dysuria, frequency, urgency. So in the absence of fever, you can see dysuria, frequency, and urgency, and even incontinence can be combination of symptoms with prostate hypertrophy or hyperplasia. So whenever you have all these present, don't think that the patient has BPH or enlargement of the prostate because of old age, if they have fever as well. So just keep that in mind. In addition to pelvic pain, they can also have perineal pain, so very focused pain. And then if you do their exam, if they let you do that, then the prostate will be extremely tender. So that is something to keep in mind. You got to be very careful because you don't want to spread the infection. On the labs and tests, they have pyuria. So again, they have on urinalysis, they have some white count, some bacteria. They also develop some cultures when you do the urinalysis. And on the blood test, the PSA or prostate specific antigen will be high. And if you have a previous PSA available, then you can compare the two and say, okay, well, this is an acute infection in the presence of all these symptoms. Transrectal ultrasound is not necessary. It's not even recommended. This will be done only if there is a very unusual, atypical presentation. Etiology, so there is two different distinct group of bacteria. If a patient is sexually active, so this will be your relatively younger patient, then gonorrhea and chlamydia are to be suspected, and these are the patients who actually commonly, in addition to these symptoms, have discharge from the penis. And the patients who are older or are not sexually active, E. coli again will become the bug of choice, or the big bacteria that can cause it. The other gram-negative rods are Proteus and Klebsiella, and the staph can also cause this. Then, of course, your treatment of choice would be ciprofloxacin or trimethoprim sulfamethoxazole in simpler cases. So you can see this is a very similar. This treatment is very similar to the treatment of pyelonephritis. So because it's the same kind of bacteria, right? So no surprise. So these two antibiotics will be preferred for this category, patients who are either not sexually active or very old, and you know that it's probably E. coli. Cephalosporins and azithromycins should be preferred for this category when you know the patient is sexually active or you've grown gonorrhea or chlamydia in the cultures. So okay, so the next is osteomyelitis, so infection of the bone. So this basically is going to be fever. So these patients will present with usually very indolent course, so not very acute. So they have fever for a few days, and preceding that or prior to that they had bone pain. So they have very localized bone pain. So this is something to keep in mind. The bone pain is not just the generalized bone aches and pains that people get with many different problems. This would be a very focal bone pain. So this would be present for a few days, and then they develop fever. So that's how this shows, because the fever develops after this infection has spread into the bloodstream. So that's how you can remember it. On top of that, they have some either overlying erythema or tenderness on the skin, or they have presence of risk factors. So remember, the osteomyelitis can be two different ways it can spread. It can be contiguous spread through an open wound, which we see quite often. So in this case, you will have some skin changes, but it can also be hematogenous spread. So patients in this case will have very intact skin, and this will be a challenging diagnosis, because you may not even think about osteomyelitis because there is nothing that shows except for localized focal bone pain. But if your patient has risk factors, then you definitely want to think about it. So the risk factors, what would be the risk factors? Any immunocompromised patient, anybody who uses IV drugs, or anybody who has a hardware or any prosthetic device in the body. So those will be the populations at risk. How do we treat them? Before treatment, so labs and tests. So we have CRP, which is C-reactive protein. It's a pretty good marker to follow or monitor the course of the infection. And you can see that we are doing this not in every infection, because generally speaking, infections are quick and acute, and they are very limited. So within a few days, people get better. But in some infections like osteomyelitis and in some pneumonias, when infections stay on and on, then you can do C-reactive protein to monitor the treatment response. And so this protein is an inflammatory protein. It will start going down when treatment is working. CBC again will show leukocytosis, so this will be good to do. And the diagnostic test of choice is MRI, generally speaking, but you can also do bone scan, which will show infection of the bone. Treatment would be debridement. So if you can see an open wound, if you can see that there is some skin involvement, you can debride it. Hyperbaric oxygen will help too. And then if it is MRSA, which is most of the times this will be the case, Staph aureus infection, not necessarily MRSA, but staph infection, sensitive or resistant, you will do cephalosporins or vancomycin. If it is salmonella, you will do Cipro. If it is gram-negative rods, then also you will do Cipro. And then empiric treatment will be with Vanco and Cipro. So you can see here is a pattern. So Vanco will cover everything and Cipro will cover the other half. So if you just do these two, then you basically are covered. And this should have been before this section. But anyway, these are special populations with risk factors. So anybody, just in general population, anybody who has osteomyelitis, and even whether or not they have risk factors, Staph aureus or coagulates positive Staph aureus is the bacteria. Then with anyone with hardware or prosthetic joint, Staph aureus or Staph epidermidis would be the bacteria. People who have sickle cell, so this is a special category. They are, in addition to Staph aureus, they can get infected with salmonella too. because they can't handle salmonella very easily. So people who have a dog bite or cat bite recently, which will basically cause contiguous spread, they should be suspected to be infected with Pasteurella multocida, and the antibiotics will cover this as well. And the IV drug users, again, staph infection, that is the biggest one, and then gram-positive rods, for example, Pseudomonas, will do it too. All right, so the next is septic arthritis. So that is the infection of a joint. So basically, again, they very simple. People usually have this is a little bit more acute and more rapid onset of symptoms. So people have joint pain, very focal. So it's just one joint, very restricted range of motion. This is the main thing. So they have swollen, red, tender joint, and they just can't move, and they have on top of that fever. So this can be older or younger patients. So young patients usually are going to be limping if the lower extremities involved. Older patients again will not walk, and then on top of that they may have erythema of the overlying skin, depending upon how deep the infection is. Labs and tests to do would be joint fluid. So this is basically the key to diagnosis. Synovial fluid will tell you the story, and then CBC and CRP again for the same reasons, to monitor response to infection in the response to treatment. And then lastly, you can do a CT scan, an MRI, and X-ray, but these are just supplemental tests, so they are not necessary to establish the diagnosis. Etiology would be again your staph infection. Gonorrhea can do it too. So remember, in sexually active adults, you must think about this bacteria. Lyme disease can cause some post-infectious arthritis or reactive arthritis, so keep that in mind as well. These patients will need doxycycline for treatment. So for regular infections, your vancomycin and cephalosporins will do the job. You may need to drain the joint for pus drainage. And then lastly, if everything fails, you can do surgery. Unfortunately, some of these patients will need joint replacement, so that will become a debilitating situation. That is why it is important to recognize this very early on, so you don't get to this point. Next is the slide that shows that how synovial fluid will present. So basically, we're just concerned with this in this slide. So septic arthritis patients have opaque fluid. It's yellow to green, and they have a lot of white cells, 15,000 to 100,000. So this is the highest number of white cells compared to the rest of the categories. And then they have a lot of PMNs, so polymorphonuclear leukocytes, and oftentimes the culture will be positive, or you can gram stain it too. And the next is spinal epidural abscess, or C. So that is another very unfortunate infection. So this is another tricky diagnosis because patients will come in with back pain, and you can see that back pain is very common. Many people get it. You see it pretty much every day. If you start practicing, or whenever you start practicing, I can guarantee you'll see back pain every day. There's no day that goes by without back pain. So with that, if somebody has fever, then we should definitely think about spinal epidural abscess, especially if they have now neuropathic pain or neurologic deficit. This must not be missed. On exam, they have focal tenderness. So this can be anywhere along the spine. It can be cervical spine or lumbar spine. And then they have very decreased range of motion, decreased sensation and strength. So the labs and tests to do would be, if you're suspecting it, usually this is where the X-ray will give some helpful indication. CBC will also help, and ESR is important in this case because ESR is again another inflammatory marker, and this shows chronic infection, and sometimes these can be chronic infections. Culture of the fluid, so you may need to draw CSF, which is extremely hard to draw in this case, but if you can get some fluid, it will show the same picture as any infection. For example, they'll have low glucose, high protein, and then gram stain or culture positive. MRI will definitely give us the picture, so usually people these days just jump to MRI and get the diagnosis. Etiology, again, it can be staph infection or gram-negative rods, depending upon what population we're dealing with. So any of these can be present. Staph is extremely common, and that is why we need to give them vancomycin and metronidazole and cephalosporin. So very broad spectrum antibiotics. Combination of these three antibiotics will basically take care of everything. You may need to drain the abscess, because as long as the abscess is there, antibiotics are not going to cut it, and then these patients are in excruciating pain. It's basically unbearable pain, so you will need to control that. They will need to limit their activity because to avoid the spread of infection. And then if there is any neurologic involvement, if the nerve is also involved now, then surgery will need to be done. All right, so now we've covered all the focal infections, and we've basically gone from head to toe. Now let's go down to a combination of infections, or a group of infections that affect multiple systems in the body. So for example, influenza is a very common infection, so flu. It will cause basically this typical scenario. Patient has acute onset of fever, high grade headache, and they feel like they got stuck by, or they got hit by a truck. That's how they present. And flu season has to be present, of course, too. Most flu infections will occur in flu season. Some patients have dry cough, but pulmonary symptoms are not always present, so keep that in mind. At-risk population, basically anybody can get it, but people who get more complications from flu are children of less than 2 years of age, elderly patients who are older than 65, pregnant patients, nursing home patients, and immunocompromised patients. These are the ones who will, if they get flu, they will be more sick, or they will get more complications. So just keep that in mind. That is why they must definitely be vaccinated if the vaccine is good enough. Sometimes it's not really that great. The labs or tests to do would be rapid flu test. It's available everywhere, so we use that. The results come back within a couple of minutes. And chest x-ray may be needed if there is some pulmonary involvement. Treatment, if seen within 48 hours of onset of symptoms, then Tamiflu will work, otherwise it will not do a thing, so don't prescribe it. Supportive treatment is the hallmark of treatment, so make sure you give them a lot of fluids, rest, and tender love support. Complications, again, if this population is affected, then these complications can develop, so they can get secondarily infected with bacteria, and now staph will start to settle in, and then they get really sick. People can get respiratory failure. There can be some neurologic involvement as well as rhabdomyolysis. So just keep that in mind. These people can get pretty sick. This is the flu virus, flu pneumonia. So you can see that there is some interstitial infiltrates on the chest x-ray, and they look quite different from each other. So you can see how flu infection can present very differently in different people. And there's a lot of patchy infiltrates. So next is HIV. So HIV is one infection that again can it has a very, very unique course. So these patients again can present with pretty much anything. Since it's a virus, it will go everywhere in the body. It likes to wander around, and what happens is people present initially with a very mild set of symptoms. They have fever and malaise, and they're sick for a few days, sore throat, headache, and then they actually start to get better. But then they can develop lymphadenopathy, so you can see some lymph nodes that are getting bigger. During the course of the infection, they get myalgias, and then they get night sweats and rashes and diarrhea, so multiple other parts of the body get involved. And you will suspect this, of course, in special populations again. So it's not your regular people who walk into your office or your emergency room that you'll suspect HIV in. So this is a special population. IV drug users, they get sick with HIV very easily, unfortunately. And then multiple sex partners, people who have high risk sex behavior, they can get it. Prison inmates, it's very common in them. So actually the newest CDC guideline is that we should check everybody for HIV because it's more common than we think. The labs or tests to do would be HIV serology. So within 1 to 2 months of developing HIV or contracting the virus, the antibodies will start to become positive. And then within 1 to 2 weeks, so even earlier on, you can get a viral load. But usually the screening test is antibody test. And then coupled with that, we need to do CD4 count, because CD4 count will tell us if the patient has developed AIDS or not. So the diagnosis or the definition of AIDS is not just the HIV infection, but HIV infection along with the CD4 count of less than 200 cells, or HIV infection with opportunistic infections. So these people have like very weird kind of opportunistic infections, which we'll talk about in a second here. And along with that, if they have HIV, then they have AIDS. So also another clue to the history would be, if you see somebody who keeps on getting very unusual infections, then definitely check them for HIV. So what are those? Before that, so the treatment is antiretroviral treatment. So I'm not going to go into the detail of that, but anyway, there are HIV antibiotics. So this is just a quick snapshot of HIV course of infection. So people come in with flu-like symptoms, they feel fine for a long time, and then the count starts to fall down, and then they finally have a crisis where all the opportunistic infections start to develop, and that's how they get really, really sick. So these are the opportunistic infections. So this slide is not very clear, I'm sorry about that, but the next one is more clear. So basically they can get infected in the brain with toxoplasmosis, cryptococcal meningitis. So remember from your earlier slides, meningitis, these people can present with all the symptoms and signs of meningitis, but they just don't get better with antibiotics, and when you test them, then of course it is a different bacteria. CMV can go to the eyes. Candida infection is very common in throat and mouth, so just keep in mind. Lung infection, again, these present with pneumonia, so again this will be your atypical pneumonia. This is pneumocystis carinii. Then histoplasmosis pneumonia, so these pneumonias are going to be your chronic duration or longer duration pneumonias. TB can take hold. Tuberculosis, another infection. Whenever you diagnose anybody with TB, because TB has become so uncommon in the western part of the world, you must check them for HIV, because they get co-infected with TB very easily. Intestines or colon can get involved with CMV, cryptosporidiasis, and then again tuberculosis or atypical bacteria. Now this tuberculosis will cause intestinal obstruction more than anything else, so these people will come in with symptoms and signs of obstruction. Skin gets involved, so you have herpes simplex and herpes zoster infections. They start to develop, and then they can get, of course, some genital infections too. This is how the opportunistic infections settle in based upon the CD4 count. So you got to keep this in mind. So based upon whatever the count is, you got to treat them accordingly. So sometimes if they come in and they've developed, for example, pneumocystic, let's start here, histoplasmosis. So just remember this, easy way to remember this table would be to remember the middle, histoplasmosis. So if you have a count of less than 150, just think histoplasmosis, you got to treat for it. And then you have to treat everything below that. So everything, like you got to treat for everybody who can get infected at this point as well. So sorry, you got to treat everybody above that. So anybody whose CD4 count is less than 150, they obviously are at a definite risk for these two as well, right? So just remember histoplasmosis at 150, and then above that is PC, so that's pneumocystis carinii and coccidiomycosis. So you got to treat them as well, and then finally they got to treat you got to treat them for tuberculosis as well. Everything below that, so if they start to drop the CD4 count even more, then remember TC, so toxoplasmosis and cryptococcus. So you got to treat them for these infections as well, and then finally atypical mycobacteria. This is how I remember it. You can memorize it in any different way, but it's kind of difficult to keep this in mind. So histoplasmosis is kind of the anchor point here, and then there is pneumocystis carinii, coccidioidomycosis, and then tuberculosis, and then below that is toxoplasmosis, cryptococcus, and atypical mycobacteria. This is a slide showing that there is a cancer that can also develop secondary to HIV. So this is a skin cancer or Kaposi sarcoma, and it looks pretty angry and pretty dramatic. And if you start to see some irregular skin lesions and they're just not getting better, then of course again check for HIV. Typically these prototypical patients will be your jail inmates or people who are at risk. Next is malaria. So very quickly, so it's not much to do with malaria, but patients can develop malaria if they've traveled to outside the country. So not everybody will get it, so again not very common, but typical symptoms again will be fever, headache, malaise, and anemia, and splenomegaly. So whenever somebody comes in with fever and headaches, remember another common symptom, then you got to start thinking about malaria if they have a history of travel. So anemia and splenomegaly would be the ones that become alarming. So if these things are present, then you definitely got to treat very quickly. Etiology, there are 4 kinds of plasmodium. So of these, Plasmodium falciparum is the biggest culprit. The rest 3 are not as dramatic, so they are usually self-limiting. But if you get a diagnosis of malaria, then you obviously have to treat them with chloroquine or mefloquine or quinidine. Complications, especially with falciparum, so Plasmodium falciparum is something to keep in mind, will cause all kinds of systemic complications. So cerebral malaria with convulsions and seizures and coma, retinal hemorrhages and liver failure and kidney failure. So you can see it's going everywhere. So that's how you keep in mind. It's just a slide showing the life cycle, so not too much on it. And then there is retinal hemorrhages. So these are white-centered hemorrhages with malaria, develops with Plasmodium falciparum. So the next infection is tuberculosis. So again, TB is a very a strong bacteria that can cause a lot of different problems. So there are different categories of tuberculosis. So there is pulmonary TB that will cause fever and chronic cough and hemoptysis and weight loss. So these symptoms are present for quite a long duration, so it's not acute. And you already are very familiar with tuberculosis, so just keep that in mind. And at first glance, when you look at it, this patient may look like a patient with lung cancer. But when you see fever, and then also you see risk factors, so special populations who are at risk for developing TB, then of course you got to check for TB as well. So this becomes your highly likely differential in the setting of risk, high risk category. So people can also have laryngeal tuberculosis, which means TB of the larynx, and they develop chronic hoarseness. And then extrapulmonary tuberculosis can affect multiple parts of the body, so it can cause intestinal obstruction, it can cause peritonitis, spinal TB or TB of the spine, that's called Pott's disease. It can go to the adrenals and cause adrenal insufficiency or Addison's disease, kidney disease, pericarditis, meningitis. So all of these things, so different parts of the body, and all of these are going to be chronic. So just keep that in mind, except for when they become really, really severe, then they present acutely. For example, people can come in with long duration of TB causing intestinal obstruction, but now the obstruction has just completely closed everything in the colon, and they come in with acute abdominal obstruction. Labs and tests to do would be acid-fast bacilli, so which can be grown. So sputum culture can be obtained. You can do skin tests for TB. You can do serum test, that's interferon or TB spot. And then lastly, you can do the nucleic acid amplification. Treatment, so remember, RIPE is the name for the combination of treatment: rifampin, isoniazid, or NIH, or you can, and this, if you're giving isoniazid, then you have to do vitamin B6 with it, because these people develop deficiency of vitamin B6. And then pyrazinamide, and then ethambutol. So remember, RIPE is the treatment. I think this is backwards. So it's rifampin, isoniazid, pyrazinamide, and ethambutol. This is a course of TB. So this is just to show that it's not all bad news. So 95% of patients who contract tuberculosis from aerosol inhalation, they actually don't develop acute TB. They go into latent infection, 95%. And then of those 95%, 5% reactivate themselves and they get acute infection. Initial 5% also, of course, are getting acute infection. And then this active infection patients, only 5%, 50% of these will die, and 95% of this arm will be cured, and then 5% will relapse. So this is how TB takes its course. This is a chest x-ray showing a cavity lesion, so you can see latent TB. So there's a lot of there's a cavity lesion showing upper lobe of the right lung. Alright, so the next is malignancy.